Well, thanks, guys, for the great discussion on the ER positive, and let's go on to HER2 positive disease now. You know, one of the more gratifying things we get to treat. You know, and so should we be giving everybody with HER2 positive disease now preoperative therapy or close to everybody? Kevin, what do you think?
Yeah, I mean, at our institution, you know, we work very closely with the surgeons, and actually for these, I'd be curious, and Beth's input on this as well. You know, I think they have a very low threshold with a newly diagnosed HER2 positive patient to send them over to us just to see should we be giving neoadjuvant therapy. I think generally, not always, you know, for those that are greater than 2 centimeters and node positive, we're giving neoadjuvant HER2 targeted therapy with chemotherapy for all patients, at least our institution. Where things become a little bit more gray are for those patients who have T1C clinically node negative, in which case, you know, if somebody's 1.9 centimeters, it's a different discussion than somebody's like 1.1 centimeters, in which case we would then likely have them go to surgery and then do something like the APT trial, you know, where patients got Taxol and Herceptin. That's generally how we approach things at our institution.
Mm-hmm. So a lot of neoadjuvant, not 100%. Right. How about you, Beth? What do you think of it?
Yeah, I think I agree with Kevin. At our institution, broadly speaking, if the tumor is less than 1 centimeter, we'll take them to surgery first because there's little chance that it's going to make breast conservation more easy, which of course as a surgeon is one reason to consider neoadjuvant therapy, and then they would get Taxol Herceptin in the adjuvant setting. With respect to all the other patients, you know, for a long time as surgeons we thought that the importance of giving neoadjuvant therapy was to downsize the tumor so that I could do a lumpectomy. And now we know, of course, in our surgical literature, it also is likely downsizing the amount of axillary surgery they may need. So certainly for the node-positive patients, the HER2-positive folks, they can have pathologic complete response rates in the axilla that are approaching 70+%. And so we know from the Z1071, the Centina data, the Canadian trial, that perhaps we can give them preoperative systemic therapy, get a complete response, and do a sentinel node procedure as opposed to a full axillary lymph node dissection. So I think most of the surgeons are on board with the literature as it relates to doing smaller surgery on the breast, less surgery on the axilla. But one thing that I've become a champion of when I'm talking to my surgical colleagues is just how important neoadjuvant therapy is now for you all, for your adjuvant therapy decisions. And I'm assuming we'll be talking a bit about the Catherine trial, but as a surgeon, I now almost feel a little bit of responsibility to refer to consider neoadjuvant therapy so that patients can get that trastuzumab, pertuzumab up front, get their optimal response, and determine whether you all need to do a different treatment on that other side.
Yeah, that's been a game changer, the Catherine data. I think you were going to tell us about the Catherine data there, Ruth.
Yeah, and I think just to Beth's point, you know, I think you wonder if Catherine will even drop our threshold for giving pre-op treatment even lower than it was. Because I think most of us would do over 2 centimeters, as you said, but I think the 1 to 2 centimeter
I
kind
like
of on
the
the
1
edge.
centimeter myself. Yeah. I've used that.
No, and
I
we
like
have
the
too,
response,
but I think it wasn't maybe it's widely done.
I agree.
So the Catherine study basically was essentially addressed this issue. It was patients who'd had at least 6 cycles of chemotherapy and HER2-directed therapy, go to surgery, and then had residual disease left. They had to have at least 1 centimeter of residual disease with or without positive nodes. And they were randomized to 14 cycles of TDM1 or to trastuzumab. And there was a really markedly improved outcome in the patients who got TDM1. I believe it was an invasive disease-free survival benefit of about 11% or something. It was one of the most positive adjuvant trials we've seen in a long time. So very, very exciting. There were some toxicities, certainly, you know, more patients stopped TDM1 than the trastuzumab, the typical things we'd seen in the metastatic setting. So I think it was really exciting. I think it makes a lot of sense because the residual disease is probably trastuzumab resistant, and you know, you're giving a different drug in that scenario, so that makes sense. And I think also, as was pointed out, is it really shows that HER2 does remain active, you know, even this residual disease, because obviously trastuzumab DM1 wouldn't work very well if you don't have HER2.
Right,
so
right.
Very exciting results, and I think they were totally practice changing. And I think for people that were maybe being a little bit more conservative about giving pre-op treatment, like Beth was saying, I think that we're probably going to start seeing more of that being done. Yeah.